everyone again, and welcome to today's webinar, How to Prep for a Medicare Home Health Survey. Whether you're preparing for your very first survey or gearing up for a follow-up, I've got you covered. This session is designed to help agencies at every stage feel more confident, better organized, and survey ready. My name is Terrence J. Finesse, and I'm the product manager at Alora Healthcare Systems. You might be wondering why a product manager is here talking about Medicare home health surveys. Well, I've been in healthcare for over 25 years. Before joining Alora, my family owned and operated a home health agency and visiting physician group with 5 locations across Central Florida. My father and I built the walls, converting a warehouse space into our very first office. We literally built it from the ground up. I was the administrative survey lead. I ran reports, prepped charts, and we survived more surveys than I can count. Today, I'm excited to help you walk into your next or first survey with a little more clarity and confidence. By the end of this webinar, you should be able to understand the Medicare survey process, be familiar with some of the top home health deficiencies, learn some practical preparation strategies, and familiarize yourself with tools available in Alora to support compliance readiness. Let's start with some background information. Home health has been flagged by both the OIG and CMS as a program that's particularly vulnerable to fraud, waste, and abuse. Because of that, home health agencies are required to undergo on-site surveys, not as a formality, but to ensure we're complying with the Medicare standards. These surveys are unannounced, although some may let you know a time frame when they may be coming, and they can come from a few different places. CMS directly, your state survey agency, or your accrediting organization. So preparation isn't optional. It's part of the responsibility that comes with providing skilled care under Medicare. Surveys are conducted at several key points in a home health agency's life cycle. They're required prior to initial enrollment, and then at least once every 36 months to ensure ongoing compliance. But those aren't the only types. You may also face an abbreviated standard survey. These are typically triggered by complaints, incidents, or data anomalies, and they're more focused in scope, but still carry the same level of scrutiny. And then there's the validation survey, which applies to deemed agencies, those accredited by organizations like CHAP, ACHC, or Joint Commission. In many states, including my own here in Florida, agencies are required to be deemed to become Medicare certified. That means they're surveyed by their accrediting organization, not the state. But here's the catch. Even deemed agencies aren't off the hook. CMS conducts random validation surveys as part of its oversight of accrediting organizations. So you may still get a visit from the state or CMS to confirm that your accreditor's standards are aligned with Medicare's conditions of participation. Compliance with the conditions of participation is assessed through a comprehensive review of your agency's operations. Surveyors gather information from multiple sources, including direct observation of care and operations, clinical record reviews, interviews with patients, their caregivers, and your staff. The length of the survey can vary based on a few key factors: your patient census, the number and location of branch offices, the number of home visits with related travel time to be conducted, and the complexity of number of issues identified along the way. When the survey team arrives, they'll typically provide you with an estimated duration based on these variables. But keep in mind, that timeline may shift depending on what they find. I wanted to start off with a quick poll to gauge everyone's home health Medicare survey experience. If you wouldn't mind just taking a few seconds to respond, I would be very grateful. And I do appreciate you all for participating. It's always helpful to know where everyone is on their journey. And don't worry, there are no wrong answers here, unless none of the answers apply and you just happen to love unannounced surveys. Looks like people are still answering, so I'll give you just another few seconds here. All right. Looks like we've got a good mix of veterans and first-timers, perfect audience for this session. And we've got a lot to cover, so let's get going. Surveyors don't just show up and start cold. Before they walk through your door, they've already done their homework. They review your licensure records, previous survey reports, including complaint investigations, and even media coverage or other publicly available information about your agency. They use this background to identify potential areas of concern that may guide a more focused review. That's why it's critical to stay proactive, especially when it comes to complaints and incidents. For Alora users, I recommend taking full advantage of the patient communication log and incident reports. Make sure your staff is actively documenting any patient complaints, even the ones that seem minor or routine. You never know what might show up on a surveyor's radar. Being honest, responsive, and consistent with complaint documentation not only supports compliance, it tells surveyors that your agency takes patient concerns seriously. Now, this part won't apply to agencies anticipating their initial certification. You likely won't have any OASIS submissions to analyze yet. But for everyone else, surveyors will have already downloaded 4 reports from the CMS National Data System. These same reports are available for you to generate through the Casper system. And I strongly recommend reviewing them regularly, not just when you're anticipating a survey. On the reference slide, I've included a link to the iCase user manual, which walks you through how to generate these reports step by step. Let's break down what each report tells them and what it can tell you. First are the potentially avoidable events, PAE, and PAE patient listing reports. These reports focus on outcomes that may or may not have been influenced by your agency's care. This includes events like emergent care, development of UTIs, or pressure ulcers, to name a few. The PAE patient listing provides specific patient charts that surveyors may review during closed record audits. When you run this report, you'll not only see your performance, you'll see how it compares against national benchmarks. Second is the agency patient-related characteristics report. This gives a high-level view of your patient population, common diagnoses, and care complexity. Surveyors use this to evaluate trends and guide sample selection. So for example, if your agency has a high rate of recertifications or a lot of clinically complex cases, surveyors may zero in on those during home visits to evaluate coordination of care and documentation consistency. And third is the HHA error summary by agency. This report summarizes OASIS submission errors, but the main thing surveyors look for here is late submissions. And why does that matter? Because it ties directly to GTAG 372, which deals with compliance around the timely encoding and transmission of OASIS data. And that brings us right into our next slide. So what is a GTAG? CMS uses deficiency indicators across all healthcare settings. In hospice, you'll see L tags, in SNFs, F tags, and in home health, we work with G tags. These tags are directly tied to the conditions of participation, or COPs. They help ensure that home health agencies are delivering safe, compliant, and high-quality care. Every member of your staff, not just leadership, should have a basic understanding of the COPs. Because surveyors will assess not only what's in your documentation, but also how well your staff understands and applies the standards in practice. Now, if you're a deemed agency, meaning you're accredited by CHAP, ACHC, or Joint Commission, you'll have additional standards to follow. It's important to always have the latest accreditation manual on hand and ensure your staff is trained to meet both CMS and accreditor expectations. But there's more. Depending on your state, you may be held to even stricter regulations than what's in the federal COPs or accreditation standards. And in the case of any conflict, the strictest rule always wins. One good example is medical record retention. CMS guidelines require home health agencies to retain medical records for 5 years after the discharge of a patient, In the Florida statutes, patient records must be maintained for 6 years following discharge. In this case, the state regulations are stricter, and so Florida agencies would need to retain records for 6 years. In Ohio, unless the patient is a minor, it's 7 years. Otherwise, it's 3 years past the age of majority, but not less than 7 years. Now take a look at the screenshot on this slide. This is pulled directly from the CMS Basic Surveyor Training. It's a great tool for agencies because it shows an abbreviated list of what surveyors are actually instructed to review. The green items represent what's covered during a standard survey. The yellow ones highlight the minimum review during a partial extended survey. But remember, you should be survey ready for all G tags, not just the ones highlighted here. If you really want to understand how surveyors think, spend time with the State Operations Manual, Appendix B. And don't judge me, but it's genuinely valuable reading. This document lays out the survey protocol, tag by tag, and shows you exactly how surveyors are trained to conduct reviews. They're not trying to surprise you with secret questions. They're literally following this guide. And to make things easy, I've included links to both the basic surveyor tool and the State Operations Manual on the reference slide at the end of the presentation. So any findings that fail to meet the conditions of participation may be considered a deficiency. So let's talk about some of the most common deficiencies agencies faced in the past year. This is one of the most commonly cited G tags, G574, which covers individualized plans of care. Earlier this year, I hosted a full webinar on SMART goals and patient-centered care planning. We walked through how to set up your care plan templates in Alora to support compliance and clinical clarity. If you missed that session or just want a refresher, I've included a link to that webinar on the resources slide. Now, when it comes to POCs, here's a good internal practice. Have your QA team review each plan of care before it's sent to the physician. This helps ensure that orders are complete, clinically sound, and survey ready. A complete order should include a problem, the planned interventions, and goals tied to those problems. And just as important, those problems should tie directly back to what's documented in the comprehensive assessment. If you're using Alora, you'll find that we've built in validations to help flag any missing elements in the plan of care, making it easier to catch issues before the plan of care leaves your hands. Now let's talk about GTAG 682, which focuses on the prevention of infections and communicable diseases. And one of the most fundamental pieces of that is hand hygiene. According to the CDC, each year, millions of people acquire an infection while receiving care, treatment, or services in a healthcare organization. Hand hygiene is one of the most important ways to address healthcare-associated infections. Surveyors and CMS expect your team to follow the most current CDC hand hygiene recommendations. And they'll be watching everything from how and when you clean your hands to how you handle gloves, equipment, and even faucets. An administrator recently shared a story with me. During a survey, the nurse was doing everything right until they went to wash their hands and then turned off the faucet with their clean hands. Contaminated surface. So as you can see, it's easy to get cited for something so simple. A link to the official CDC guidance is included on the resource slide, and I highly recommend reviewing it with your team. Here's a quick reminder of when your staff should be cleaning their hands. Before touching a patient, before performing an aseptic task, before moving from a soiled to a clean body site, after touching a patient or their surroundings, after contact with blood, body fluids, or contaminated surfaces, and immediately after removing gloves. The CDC also provides guidance on when to use hand sanitizer versus soap and water. So make sure your policies and procedures align and that your field staff are trained and observed regularly. Also, they shouldn't only be performing these standards when they're being observed. It needs to be second nature for them. If the clinician is doing something out of the ordinary by washing their hands multiple times, and you don't want the patient to ask what they're doing in front of the surveyor, they will inadvertently tell on you. And I'm sure most of our veteran agencies here today have a similar story of how patients reveal something that have caused surveyors to dig a little deeper. To help make hand washing education a little more memorable, here's a fun one. Scripts.org put together a playlist of songs with choruses that hit the 20-second mark, the perfect timing for proper hand washing. We're talking No Scrubs, Love Shack, Since You've Been Gone, and even Shake It Off for the Swifties out there. There's a link to the full playlist on the resource page if you want to bring a little fun into in-service training. Bag technique is another critical component of GTAC 682 for the prevention of infections and communicable diseases. I mean, just look how horrified that animated character was with the poor bag technique. Every home health agency should have a clear written standard for a bag technique outlined in its policies and procedures. And here's the key. Surveyors will evaluate your staff's actions against your own agency standards, not someone else's, not a textbook, yours. That's why it's essential to make sure your entire clinical team is trained and confident in the correct technique, that you conduct skills checks regularly, and perform routine observation visits in the field to ensure consistency and compliance. Even small deviations, like placing the bag on an unclean surface or forgetting to disinfect between visits, can be cited if they contradict your agency's written protocol. So don't leave it to chance. Train, observe, and reinforce. Because bag technique is more than a procedure, it's a surveyor-watched performance. One thing you absolutely don't want to happen during a survey. A surveyor observes a home visit and discovers that the medications in the home do not match the medication profile in the patient's chart. According to ACHC, this issue, cited under GTAG 536, was found in 44% of surveys in 2024. That's nearly half of agencies being cited for a breakdown in medication reconciliation. There is evidence that medication discrepancies can affect patient outcomes, and medication reconciliation is intended to identify and resolve discrepancies. It is the process of comparing the medications a patient is taking or should be taking with current ordered medications. The comparison addresses duplications, omissions, and interactions, and the need to continue current medications. In Alora, our nursing visit notes include a prompt asking whether medications were reviewed during the visit. Your QA team should be monitoring those responses closely because they reflect whether medication reconciliation is being treated as an active routine responsibility. And it's not just the nursing job either. All disciplines should be educated to report medication changes, communicate with the physician, and reinforce that medication review is a continuous part of patient care, not a one-time task at the start of care. Inconsistent med profiles not only raise red flags for surveyors, they also pose real safety risks for your patients. Surveyors already have access to your OASIS submission data, and they'll be looking at your agency's track record for timely admissions and resumptions of care. You should be admitting patients within 48 hours of the date of referral, or the patient's return home from an inpatient facility, or on the physician-ordered start of care date. This isn't just a documentation formality. It's a compliance standard that affects both your quality reporting outcomes and your 5-star ratings. Make sure your scheduler understands the importance of these timelines. If they're asked to move a scheduled admission beyond the 48-hour window, they need to confirm that there's an order for the revised start date and that it's documented in the patient's chart. In Alora, when you perform an OASIS analyze, you'll see a section that highlights whether or not your agency is meeting this standard. It's reported alongside other best practice benchmarks used in CMS's quality reporting programs. So again, educate your team, empower your scheduler, and make sure verbal orders are documented. Surveyors will already know whether you're consistently meeting the standard before they even step into your office. And another important timeline to be on top of relates to discharge and transfer summaries. Timely communication during discharge or transfer is not just best practice, it's a regulatory requirement. You must send discharge summaries within 5 days of the discharge date, transfer summaries within 2 days of becoming aware of the transfer. In Alora, we make this easier with built-in faxing capabilities, so you can instantly send the summary to the receiving provider and retain a fax confirmation log as your proof of submission. We also offer reporting tools to help monitor compliance with these timelines, so you can stay ahead of potential deficiencies. But none of that matters if your team doesn't know the expectations. So make sure your clinicians are educated on when and how to complete a discharge or transfer summary and the importance of sending it promptly to the appropriate provider. Because even a small delay can raise a flag during a survey. And that brings us to our next point. Let's take a moment to talk about what's really at stake when survey readiness falls short, the true cost of deficiencies. We've looked at just a few of the most common 2024 deficiencies, but they're only the tip of the iceberg. So if you'd like to see the full breakdown, I've included links to the latest deficiency lists from both ACHC and CHAP on the reference page. But here's what matters most. A deficiency isn't just a technical citation. It can mean delayed or denied payments, disruption in patient care, and increased stress for your staff who now have to scramble to correct issues that could have been prevented. And let's not forget the reputational risk, especially for agencies that rely on referrals and partnerships. That's why staying survey ready isn't just about compliance, it's about protecting your agency's stability, credibility, and capacity to serve. So how do you protect your agency from preventable deficiencies? It starts with having a clear, organized plan. And that's where your survey preparation checklist comes in. One of the most effective things you can do to stay ready is to develop a survey preparation checklist tailored specifically to your agency's operations. Your checklist should cover the 3 major pillars of readiness: operational, clinical, and human resources. Start with the State Operations Manual. It's your blueprint for survey expectations. Use it to guide the structure and content of your checklist so nothing gets missed. If your agency is accredited or plans to be, there are great resources available. ACHC offers a comprehensive preparation checklist that's available online, which addresses the COPs and their own standards. I've included a link to that on the resource page. CHAP accredited agencies can access a detailed prep checklist directly through their accreditation portal. These tools aren't just helpful, they're practical and surveyor aligned. You can build your internal checklist around them or use them as a starting point to ensure your readiness efforts are systematic, not guesswork. A well-structured checklist keeps your team focused, confident, and organized, and helps ensure that nothing falls through the cracks when surveyors walk through your door. So let's talk about the strategies when they do walk through the door. When the surveyors show up, stay calm. The best defense is a well-prepared team with clearly defined roles. Start by designating a clinical survey response lead. This person is your go-to for all clinical questions during the survey. They should be confident, knowledgeable, and deeply familiar with both the conditions of participation and your agency's policies and procedures. Their job is to answer questions clearly, sit with the surveyor as needed, and represent your clinical operations with confidence. In short, they're your clinical compliance ambassador during the survey. This might be your DON or a clinical supervisor. Next, you'll need an administrative survey response lead. This person supports the clinical lead by managing all the non-clinical logistical tasks behind the scenes. They should be able to instantly generate any required reports, request surveyor licenses from Alora support for our Alora customers, and coordinate their own survey support team to quickly fulfill documentation or record requests. This could be someone like an office manager. These two leads should be tightly aligned and prepared to work together like a relay team. Next, have a survey binder ready. This should include at minimum an up-to-date organizational chart for your parent and branch offices, current licenses and permits, your CMS 855A approval letter, policies and procedures, a copy of your admission packet, and documentation identifying your administrator, designee, and letters of appointment. And last but not least, coach your team. Remind them to be honest, composed, and concise during surveyor interviews. Only answer the question that's asked. No need to over-explain. Now that we've covered who's doing what on survey day, let's take a look at the key reports your administrative survey response lead should have ready. Your administrative survey response lead should be prepared to generate key reports quickly and accurately. These are the reports surveyors often request within the first few minutes of arriving, so they should already be saved as favorites in Alora for fast access. Let's walk through the essentials. Unduplicated skilled care admissions. Surveyors use this to determine the survey sample size. You can pull this from the admission detail census report filtered for the past 12 months. At the bottom of the final page, you'll see the total unduplicated patient count. That's the number they're after. The active skilled patient census. This should include all active patients receiving skilled services, regardless of payer source. Remember, if you're Medicare certified, the conditions of participation apply to all skilled patients, not just Medicare. Be ready to provide a list of discharged patients from the past 6 months. This helps surveyors select records for retrospective review. They'll want a current roster of all field and office staff, including contracted clinicians. Make sure this list is up to date and includes all required credentialing info. If your agency maintains a complaint or abuse log, have that ready as well. If you're using Alora's patient communication log and assigning communication types, you should be able to generate this report easily. Having these reports pre-saved, accurate, and ready for handoff creates a strong first impression and helps you stay one step ahead of the surveyor. And speaking of staying ready, let's take a look at how Alora's built-in tools support you throughout the survey process. Our platform is built to help you with compliance, not just when the surveyor is knocking. For starters, we have our Oasis Analyzer, our own scrubbing tool that gives real-time feedback on best practices, highlights potential conflicting responses, and even summarizes hospitalization risks so you can address them proactively. Our care plan-driven documentation ensures that your entire care team, including home health aides, is charting interventions and tasks directly tied to the plan of care. This supports both compliance and continuity of care. We also offer powerful compliance-focused dashboard widgets such as incomplete documents, unsigned orders, expiring staff credentials. If you're in a pre-claim review or post-claim review state, our pre-claim review monitor widget makes it easy to stay on top of submission timelines and statuses. Our custom documents tool allows you to build and collect consents to treat or other agency-specific documentation electronically, right within the patient chart. For infection control, our COVID pre-screening tool helps reduce exposure risk by supporting safe entry protocols before your clinicians even step into the home. Behind the scenes, we've got a robust QA center for auditing all document types in one centralized location. And for deeper insight, Alora includes a suite of reports for ongoing monitoring and analysis. But here's the bottom line. Technology can support you, but it can't replace strong team practices. Let's talk about what your agency can do beyond the EMR to stay truly prepared. Here are some bonus tips to improve your survey readiness. Here's the first tip that can save your agency from a lot of headaches. Treat chart audits as a proactive training tool, not just a compliance checkbox. Chart audits fall into two types: clinical record audits and billing audits. Let's start with the clinical side. CMS recommends that your QI coordinator perform monthly audits, reviewing at least 5 start of care records and 5 discharge records. Pick them at random to get a true cross-section of your patients and care teams. Then compare OASIS responses to other visit notes from around the same time. This helps verify data accuracy and documentation consistency. Some agencies stop there, but the ones that stay survey ready often go further. They audit a larger sample, or even 100% of records, especially when they're tightening up their processes. Now for billing audits. This is where agencies either lock in clean claims or get hit with avoidable denials. I recommend a 100% audit at the end of every billing cycle. At my agency, we had a tool that we completed before billing anything. It covered everything from face-to-face compliance to confirming that the referring diagnosis matched the plan of care to making sure orders were signed and visit frequencies were followed. Bottom line, chart audits help you catch things early, reinforce expectations, and most importantly, turn real documentation into real learning opportunities for your team. My next tip: QA visit documentation like it matters, because it does. I recommend a full QA review of all visit documentation, not just to check a box, but to catch trends early and make chart audits easier down the line. What should you be looking for? Progress towards goals, evidence of care coordination, supervisory visits, homebound status justification, and medication profile review and reconciliation. Let me tell you a quick story that I'm sure many of you can relate to. We had a nurse, great with patients, but consistently over 2 months late with his documentation, which created a massive bottleneck. And I know some people would ask, why did we keep giving him visits? And it's the same reason many of you would. It's hard to find nurses. And the patients absolutely loved him and specifically requested him. Even the patient's doctors would request that we send that nurse. Well, anyway, after a lot of pressure, we'd get his notes in. But when we finally reviewed them, every visit note said the exact same thing. It was almost like they were photocopied. Same interventions, no variation, no signs of progress or even change. Here's the issue with that. Documentation that doesn't reflect progress towards goals raises red flags for surveyors. And beyond that, if it doesn't demonstrate skilled need and medical necessity, it threatens reimbursement. So even when staffing is tight, even when the nurse is like family to the patient, you still have to ask, is this note defensible? Does it support the care being billed? Your QA reviews should catch those issues before surveyors do. Here's a tip that agencies often underestimate. You need to control the schedule, not let it control you. At our agency, we assigned a dedicated scheduler to each clinical team. Their role wasn't just data entry. They were responsible for making sure visits were scheduled exactly according to the plan of care. If new orders came in, they updated the schedule. If a clinician couldn't see a patient, the scheduler adjusted accordingly to stay within ordered frequencies. Clinicians were expected to review their weekly or daily schedules and confirm them with their scheduler. They were also required to notify the scheduler if they couldn't make a visit, so it could be reassigned or rescheduled appropriately. Knowledge of your clinical team's schedules helps you to quickly identify who can handle additional visits for any day of the week. Schedulers would routinely follow up on incomplete visits, asking clinicians whether the visit was performed and if it just hadn't been documented. This helped close loops in real time, not weeks later when you're doing payroll or trying to bill. And one key rule: schedulers were not allowed to add visits unless an order was already in the chart. No assumptions, no "I'll get the order later." Why? Because we've all heard the horror stories. Agencies where clinicians had full control of their own schedule and started seeing patients without orders or forgot to enter verbal orders into the system, moving recertification visits out of the recertification window, moving start of care visits past the 48-hour window without an order in the chart, and so on. It might seem convenient in the short time, but it is a huge compliance risk. Surveyors will absolutely ask, show me the order for this visit. And if it's not there, that visit shouldn't have happened. This is also why it's a smart idea to do a billing period audit to make sure every scheduled visit lines up with an order and the plan of care. The bottom line here, your schedule should reflect clinical intent, documented orders, and actual delivery of care. Otherwise, it's just a liability waiting to be discovered. My next tip is to treat observation visits like a dry run for survey. Your case managers and clinical supervisors should approach supervision visits with the mindset of a surveyor. Are clinicians following best practices? Do they understand what they're documenting and why? Would their visits stand up to scrutiny? CMS recommends performing clinical audit visits quarterly. You pick 3 to 4 patients, either across the agency or within a specific team, and have a clinical supervisor or peer auditor attend their start of care visits. Here's how it works. While the admitting clinician completes the assessment, the auditor independently documents responses to the same OASIS items. Then both versions are compared. Where the answers don't match, the clinician and auditor should sit down together and talk it through and ask, why did we code this differently? Was it a misunderstanding of the OASIS item? Was more probing needed during the interview? This process isn't about catching people. It's about building clarity and confidence. You can also consider applying similar audits at other key time points, not just the start of care. The goal is to verify the accuracy and consistency of your OASIS data and to strengthen clinical reasoning across your teams. And I hope this isn't new information to everybody, because this is actually in the OASIS guidance manual. I have a link in the resources slide for that manual as well. Here's something surveyors also pay attention to, especially during home visits. Is the patient or caregiver aware of the admission packet and where it's located? Do they have a copy of their plan of care that includes goals, ordered interventions, medications, and their schedule? Do they know who to contact with questions? Are they satisfied with the care they're receiving? Surveyors may even stay behind after your staff leaves to speak privately with the patient or caregiver. So don't assume that what your staff says or does ends when the front door closes. This is just an opportunity to coach your clinicians to be survey ready every day, not just when someone's watching. Here's one of the most underused but powerful tools in your survey prep toolkit: mock surveys. And not just once a year, every 3 to 6 months. Think of it like this: if your team only practices after receiving a survey notice, you're probably already too late. Mock surveys allow you to pressure test your readiness and catch issues in a safe environment before a real surveyor does. I recommend using the State Operations Manual as your guide. It outlines the exact CMS survey protocols so you can apply the same lens a surveyor would. Assign roles. Someone acts as the surveyor. Someone else shadows the visit or reviews the charts. And don't just skim the records. Ask questions, interview staff, observe care, review documentation line by line. After the mock survey, document your findings, the good, the bad, and the needs work. This isn't just about identifying deficiencies. It's about uncovering patterns like missed supervisory visits, inconsistencies in OASIS coding, or patients who never received a copy of their rights. And here's the kicker: your follow-up matters as much as the mock survey itself. Use the findings to guide in-service education, policy updates, or workflow changes. Mock surveys aren't just a drill. They're a leadership tool, and when done right, they shift your agency from reactive to proactive. Last but not least, let's talk about survey resources. And no, I don't mean just shoving them in a binder on a shelf. If you want your team to be truly survey ready, you need to make sure that critical resources are accessible, visible, and always up to date, not just during survey season. At a minimum, you should have quick access to your agency's policies and procedures, Appendix B of the State Operations Manual, which outlines the conditions of participation, your accrediting organization standards, whether that's ACHC, CHAP, or Joint Commission, and the Medicare Benefit Policy Manual, which covers eligibility, services, and coverage criteria. But here's the key. These shouldn't just live in your administrator's inbox or in a forgotten drive folder. Post the links in your internal portal. Include them in onboarding. Reference them during audits and in-service trainings. Encourage your team to treat these resources like a shared GPS, especially when compliance questions come up. Alora has a document library under Tools, which agencies can use to share resource documentation to their staff. Also, and this is important, check for updates regularly. Medicare guidance, survey protocols, and accrediting body standards do change. What was compliant last year might not hold up today. Designate someone like your QAPI coordinator or compliance officer to review and refresh your shared documentations at least quarterly. Having these resources readily available shows surveyors that your agency doesn't just react to compliance, it lives it. I received some advice from a couple of our high-performance agencies that I wanted to share. Adopt a healthy philosophy. Stay ready, don't get ready. Do all the things right along the way and prep becomes much easier. And one of my favorites, if you're being observed and feeling frazzled and you're questioning whether you should be washing your hands, wash your hands. All right, here are all the resources I mentioned, along with some additional items I thought would be helpful. And if you haven't done so, you can download the presentation deck from the handouts link as well. Thank you everyone for spending time with us today. If you're not an Alora customer and interested in a demo, I do have our sales information available here, sales@alorahealth.com. But if you are an Alora customer and have some questions about functionality, please reach out to our support team, support@alorahealth.com or 800-954-8250. Thanks again, everyone, and I hope you enjoyed the rest of your day.